Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Rich Duzak from Emory University, and this session is the second of two advanced vascular and interventional radiology add-on modules entitled Vascular and Interventional Radiology Documentation. This module is specifically targeted to address components of Level 4 of the Vascular and Interventional Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Nearly all of the other level requirements for vascular and interventional radiology are addressed in the various modules in levels 1 through 5 of Replete. And so if you complete this module and the prior one on vascular and interventional radiology coding, in addition to all 5 levels for diagnostic radiology, you will have fulfilled all ACGME and ABR economics milestones requirements for VIR. A detailed requirement grid accompanies this module on its landing page. I encourage you to take a close look at the RSNA's website to learn more about how modules map to different levels in different programs. The learning objectives for this module are as follows: to outline the many important roles of the interventional radiology report, to describe the various components of interventional radiology services that require specific documentation for billing and/or quality tracking purposes, and to understand how standardized report templates created by professional societies can be readily implemented into an interventional radiology practice and used to comply with the many and challenging regulatory requirements impacting the specialty, as well as to optimize legitimate revenue. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. You've seen this flowchart many times so far in Replete, and I'll remind you about it yet again. It's the sequence of events leading up to a radiology examination and the sequence of events after you generate your report that together capture the information that's necessary for you to get paid for your services. Most radiologists focus on the steps highlighted here in blue because those are the steps where they have the most direct control over what happens and what doesn't happen. But you know from prior modules in Replete that if you ignore the many steps in white, that you'll leave your payment chain vulnerable and probably leave legitimate revenue on the table, as well as subject yourself to potential regulatory compliance challenges. Fortunately for interventional radiologists, the clinical model in which the practice is increasingly moving creates opportunities to have more control over more steps along the way, the ones I'm now additionally highlighting in blue. Because if you see your own patient in clinic, you'll be the one initiating the service, meaning putting an order into the electronic medical record if required, and working with your staff to schedule and register that patient for any necessarily procedural or other services. The information is often lost in these steps in a diagnostic radiology practice. Why? Because another physician is ordering and scheduling the test, or the patient may be getting registered for a service at a site where you're not personally present. In a clinically oriented interventional radiology practice, however, you will have a lot more control over these steps, but only if you choose to. And I would encourage you to do just that, because it translates into more control over your revenue destiny. The other important step in interventional radiology that distinguishes it from diagnostic radiology, also now highlighted in blue, is that you're usually the one performing the examination. And so that means that you will have near complete control over what gets done and what doesn't, meaning that you can be sure that your patient receives the services that are most medically necessary, and that all I's have been dotted and T's have been crossed with regard to meeting regulatory quality and billing requirements. Again, when you are practicing interventional radiology rather than diagnostic radiology, your destiny, at least with regard to these events, is much more in your hands. We talked in the last module on interventional radiology service coding. You know my bias by now. Unless you're personally a radiology certified coder, you shouldn't be doing your own coding. But you do need to make sure that you've got a great team of experts doing it for you and working closely with you to make sure that they're capturing all information necessary to get you paid fully, completely, and compliantly for your work. From that last module, you also know that coders can only do that if you do your job. And so I come back to documentation and reporting in this flowchart as the focus of this module. If you don't do a good job here, your coders can't do a good job when it's their turn. What this all comes down to is critically looking at your revenue chain for areas of potential vulnerability, the weak links in that chain, so to speak, and proactively spot welding those links to make sure that you get paid legitimately, no more or no less, for the work that you do. In many practices, physician documentation is a really weak link in that chain. But with appropriate attention to detail, leveraging professional society resources, you can make this one of the strongest and most reliable links in your chain. It all comes down to the quality of your radiology report and the cultural and infrastructural commitment you're willing to make to get you there. Your procedure report, like any other medical record entry, serves a variety of important roles, and I think it's useful to put that in context. While we have focused on regulatory and payment issues throughout all of Replete, as we get into the regulatory weeds, let's not forget that the primary goal of the medical record, including your report, is to convey clinical information to your clinical colleagues. And so attention to detail and readability is important. But we all know that your report is used for many other things as well. It serves important legal and regulatory roles, capturing information necessary to ensure facility and service line accreditation and certification, and details to help defend you in the setting of a malpractice claim. What we talked about in the last module and this one, though, will be the report's role in helping you do the best job you can with getting paid and remaining compliant. In the changing healthcare environment that is still based largely on fee-for-service, but with increasing emphasis on pay-for-performance. What that means is that you want to get into the habit of capturing information in your reports that will meet your payment and compliance needs as our health systems continue to evolve. And so while there are some things you need to capture to optimize payment under fee-for-service and other things that you'll need to capture to optimize payment under pay-for-performance, in the real-world, busy clinical practice environment, you can't dictate each case differently because you don't know in real time what each payer will require. That means the best approach will be to develop a mechanism for reporting that meets all of these needs, each and every time, in as seamless a manner as possible. And that's where structured reporting comes into play. You see here an admittedly simplified checklist of the things you need to document in your report to get paid. To bill for any service, you need to use CPT codes. They describe what you did, and so your report will need to do just that. You'll also need to fulfill payer medical necessity requirements. That means making sure that your ICD codes for signs, symptoms, or diagnoses match an approved list for the CPT codes you billed. And so your report needs to describe why you did what you did. And finally, you'll need to describe special circumstances surrounding the service. Most of the learners in Replete are in ACGME-approved residency or fellowship training programs, and so the teaching physician supervision rules that we described in Level 1 and in Level 5 come into play here. Let's go back, though, to the what you did step, because ICD coding rules are pretty much the same for diagnostic radiology and interventional radiology, and teaching physician rules apply to all services rendered by trainees. You remember from the last module that as an interventional radiologist, you'll be reporting codes from a bunch of different categories. It's admittedly a daunting list. But I believe that daunting list can be demystified. Let's spend just a few minutes and run through each of these quickly, and then share some approaches to make sure that you capture appropriate information when you prepare your reports, each and every time in as automated a manner as possible, so that you can focus as much of your energy and your thinking on taking care of patients in your day-to-day practice, rather than getting too distracted on a per-case basis, worrying about whether you need to say this or say this in that report or this one. For the diagnostic portion of your procedure, that's the part typically reported using the 70,000 series radiology family CPT code or codes that you may be reporting. This is pretty easy. Describe what you did in detail. And describe what you found in detail. The point here is that at least part of your billing will be for interpretive work, and so make sure that you provide a full interpretation. As an example, say you did a 3-vessel visceral angiogram for unexplained GI bleeding. Simply stating, quote, visceral angiography demonstrated no bleeding is nominally correct clinically, but it doesn't reflect exactly what you did and what you saw. Instead, I would encourage you to say, quote, evaluation of the celiac, SMA, and IMA distributions each demonstrated no evidence of bleeding. Now your coders know that you evaluated all 3 distributions, which will permit them to essentially capture 3 times as much work for you. The rules for the invasive portions of your procedure are pretty much the same. Describe what you did in detail, and describe how you did it in detail. Depending upon the individual service, how this impacts coding and reimbursement varies, so it's best to get into the habit of providing more rather than less documentation on a routine basis. So if you stent an iliac vessel, don't just state, quote, an iliac stent was placed. Describe instead what vessel you accessed, how you crossed the lesion, where the lesion was, what stent you used, and what the vessel looked like both before and after your intervention. Parts of that detailed description can make a difference for both professional and technical billing. Imaging guidance usually refers to needle access, and this is typically more important for less complex interventional radiology procedures such as venous access services and biopsy procedures. Be sure to describe what modality you used, ultrasound, CT, and/or fluoro. For some services like vascular access, as you saw in the last module, you can code for each modality you used. And for other services like an abscess drainage, it really doesn't matter. They're one-size-fits-all codes. But rather than focus on those exceptions, I would encourage you to focus on the big picture. If you describe your guidance modality each time, your coders can figure this all out on the back end. And make sure you describe how you use that imaging to them. For example, for ultrasound, you'll need to document that you archived images, which makes a difference with regard to being able to use those guidance codes or not. Supervision and interpretation is similar to imaging guidance, but for various procedures is reported separately. Although these so-called RS&I codes are increasingly being bundled into base surgical codes, meaning that the invasive component procedure documentation covers this, for some services it is still separately billed, and that means it requires distinct documentation. As such, even though it's intuitive, don't just say that the left renal artery or right hepatic artery was catheterized. State that it was catheterized using fluoroscopic guidance and what kind of anatomy the patient has, because right hepatic artery anatomy, for example, is quite variable. And also state how you did it. Moderate sedation used to be bundled into most interventional radiology surgical procedure codes, and it's now separately billable for many services. That said, the reimbursement isn't very much, and CMS doesn't pay for professional services in the hospital setting for the sedation beyond the first 15 minutes. So some practices are trying to decide if it's really worth it to even try billing for this, given the hassles of documentation. But if you want to bill for moderate sedation, you'll need to describe who was monitoring and evaluating the patient while you were performing the procedure, what drugs you used, and, since these are time-based codes, how long you were personally present in the room while the sedation was being administered. And finally, there are a whole slew of quality metrics that need to be documented if you participate in qualified clinical data registries and want to use that data to potentially get a bonus under MIPS, the Merit-Based Incentive Payment System. For fluoroscopic guided procedures, you'll need to document fluoroscopy time and radiation dose. And given concerns about nosocomial infections, for a lot of services like central lines or implantable devices, you'll need to document the use of sterile barrier technique and/or the timing of antibiotic administration. That's a lot to swallow and a lot to remember. So unless you've got a photographic memory and can keep up with all of the changing rules, you'll be well served by using some sort of checklist approach to documentation. Checklists will help you remember what to document, but they alone still mean you need to remember the preferred wording for each and every one of these things. My advice to you is to try not to reinvent this wheel, because the Society of Interventional Radiology has done a great job over the last few years creating standardized reporting templates. The Society has published a user's guide available on its website and has a whole host of templates that can be readily imported into your dictation system. Are you a Society of Interventional Radiology member? Why am I asking? Because these resources for interventional radiologists are all member benefits, meaning that if you're a member, the SIR won't charge you for any of these. And if you think about how much time and energy you'd need to invest to create your own report templates, that makes this member benefit alone a terrific deal. Remember, for trainees, membership is just $50 a year. If you're a member, you can go to the SIR store on the Society's website and download an XML file. If you open the file in Word, you'll see a lot of gibberish like this. But in the popular, commercially available report dictation software systems, this gibberish will be converted to text and pull-down menus that you can then readily customize to your own practice's needs, obviating the need for you to reinvent this huge inventory of wheels on your own. When you do that and open up your report template, you'll see something that looks more like this. Since every template is different, but designed to capture unique information necessary for each unique procedure, the fine print here isn't as important as what these report templates do for you. They provide very specific information about procedure details to allow you to capture CPT codes. That's important not only under fee-for-service, but also under the pay-for-performance systems like MIPS. You've seen this graphic before. If your blue line of base reimbursement isn't where it needs to be, then your green bonus won't be as high as it should. The templates also remind you to input appropriate clinical history information, permitting accurate ICD-10 coding. That's important not only for medical necessity determinations under fee-for-service, but also in risk adjusting your case mix to permit the necessary hierarchical condition category, HCC coding, so that CMS can correctly calculate your MIPS composite cost score, shown here in green, and appropriately risk adjusted. The templates also have fill-in-the-blank slots to make sure you capture all information necessary for QCDR, Qualified Clinical Data Registry reporting. That information becomes the basis of your MIPS composite quality score, shown in the red slice of the pie. And for those of us in teaching facilities, the templates remind us to provide an attestation about the level of supervision that we provided. That's important for keeping us out of compliance trouble that could lead to either fines or jail time. And finally, the more complete and more structured your reports, the more readable that they will be to Watson or whatever artificial intelligence interfaces you may be using in your practice or may soon implement and adopt. You've got enough to do during your busy clinical day to make sure that you keep your reimbursement chain as strong as it needs to be. And that's why I'm encouraging you to avail yourself of your professional society resources to make this all as easy as possible. Ultimately, the goal here is to set up a robust and enabling infrastructure that will allow you to capture all necessary information in as easy and non-obtrusive a manner as possible, so that your payment chain remains intact without you having to think about it all the time. In summary, then, the complex nature of interventional radiology services, as well as the changing manner in which such services are reported to payers, creates documentation challenges for busy interventional radiologists. Documentation deficiencies expose physician practices to risk with regard to accreditation and certification, as well as liability exposure, and additionally jeopardize their capture of legitimate revenue. Standardized reporting templates created by the Society of Interventional Radiology, like the diagnostic ones created by the Radiological Society of North America, can help interventional radiologists overcome many of these challenges. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. If you're in a VIR training program, the prior module on interventional radiology coding, as well as this module on interventional radiology documentation, will, together with the 5 replete core courses, fulfill your ACGME and ABR milestones requirements in economics. More information on the Replete initiative and additional resources are available on the RSNA's website, and specifically on the landing page for this module. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.